like to acknowledge the traditional custodians of the land on which we all meet here today and respect to the elders past, present and emerging. I would like to open this meeting at 2:07 p.m. So on today's agenda, I would like to introduce our speakers today from CareLynx. Sue, I think you're doing the PowerPoint presentation, is that correct? And then
I am.
So Sue, I will hand over to you. Thank you.
Thank you. Hello, everybody. Actually, I'm standing in for Lauren, who is off helping a service today that's had a unannounced. So I will I've got a little presentation here for you. But those of you that don't know me, I have been in aged care for a very long time now. I started my, management experience. I worked for TRICARE for a little while when I started out, and then I went to Mornington Island as a service manager of the aged persons hostel up there. And for those of you that were on sooner, Vicky taught me how to do RCS really, and then taught us all again how to do ACV. So when I was the service manager up on Mornington, we had a network like this that connected all of the residential facilities in the far north, and I have to say it was very much my lifeline. So I am delighted to see that NQPHN is doing this. I recently did the nurse advisor contract down at Innisfail, and we were joining you as part of that. So it has, I think it's really great to have these opportunities to get together and chat and share resources. So Lauren was going to present to you today, but like I said, she's off helping somebody. So we were just going to give you a bit of a rundown about what we're seeing in the industry at the moment, specific as nurse advisors and specific to residential. So a little bit about CareLynx, what those compliance concerns are that we're seeing, what we're just a snippet about what we've found in the strengthened standards, and then a little chat about the 24/7 RN thing and leveraging some technology. So about CareLynx, so we are a group of nurses that started out up here in the far north Queensland, and we really just wanted to make aged care a lot simpler. As Maureen and I started out nurse advising, and we were helping little services, and we could see that consultants had been there before us. So we really wanted to build a sustainable solution and support services to reduce their risk, and I guess also give that support to service managers, so there is someone that you can just phone a friend. We started out with a bunch of spreadsheets that we used to do our remote monitoring from, and our nurses kept breaking our spreadsheets. So we put it into a system, and we now have a cloud-based platform that has built-in clinical pathways and really supports nurses and staff to work through care delivery. A little bit about us. So as I said, Maureen and I founded the business, and we have been working as nurse advisors for about 15 years now. We are nurses first and foremost, so everything we do does tend to go back to the nursing process and supporting facilities in delivering care and services. So as we've grown and collected people along the way, we have a team now that supports services in all aspects. So chefs, care support, finance, human resource management. As I mentioned to you, I just did the nurse advisor role down at Innisfail, and they had the enforceable undertaking, and that was a whole of service piece of work. And lovely, I can't see them here today, but they have transferred to Auscare, so it's been a really lovely outcome for them down there. So we've got a team of staff that work with us, and And here's their lovely picture. This is a nice slide, Rach. Well done. So on Kieran's side is our product side, and under Rachel is our nurse advisors and the founders. So I thought Lauren had reached out to all of us and said, okay, guys, what's the top 5 and what are the things that you're seeing at the moment in the space and in non-compliances, and what are the topics that residential facilities are having, not necessarily new, but we see themes come through in multiple reports. And one of the things, so we've got about 5, I think, but one that seems to be quite new and quite popular at the moment is risk related to diagnosis. So we've seen that both in the community sector and in residential. So we know we have the high prevalence, high incidence, those risks, and they are still on the list. But this is one specific to if you haven't identified that risk related to diagnosis. So if your resident has a mental health condition that might make them refuse care, then there's a risk related to that diagnosis, and that risk would be in their refusal of care that they are more likely maybe to get an infection, or more likely to have some, if they're not cleaning their teeth, then to have some oral hygiene issues, and then potentially that can lead to the malnutrition and all of that sort of thing. So the risk related to depression perhaps might be that social isolation, and how you're actually working on those risks related to diagnosis. Not that you're just identifying it. So in the case of depression and social isolation, but actually what you're doing to manage and support that resident. Restrictive practice and managing psychotropic medication is still top of the pops. We are seeing that the Commission is really starting to dig down into those registers, so your psychotropic register, making sure that you are capturing what you're actually doing to reduce it. So demonstrating that you have approached families, you have approached GPs, you continue to try other strategies to reduce restrictive practice and to reduce the use of the psychotropic medication. Another service that we're helping at the moment has really had a great continuous improvement project, which was getting their doctors on board and really identifying the side effects that go with the psychotropic medication, supporting the service. So they don't have a lot of RNs and they are struggling with their 24/7, but supporting carers and non-clinical managers to identify what might be side effects attached to those medications. And then on their 3-monthly review, they have a conversation about, okay, so is this the lowest therapeutic dose? Is this the lowest we can go? What else can we do? And actually the doctors writing that in the discharge summaries or sending those notes back to the facility so that they can demonstrate that they are actively pursuing that reduction in the restrictive practice or the psychotropic medications. Behaviour support plans. So I think what we continue to see is that behaviour support plans are not tailored. I think you all know that they need to be tailored, but I think the challenges are that sometimes we run out of options. And look, it happens to all of us. Look, I've been in the industry for 25 years now, and you run out of options. So absolutely engage with specialists and get in help. Vicky, that was what we got Tara in to come and help us down at Innisfail. So Tara Quirk is a dementia specialist. And, you know, we just had some clients there, some residents there that we were really struggling to come up with interventions that we might be able to support them with. So reach out, get help, Keep getting help. DB Mass, if they come in and they give you a report and they give you some approaches and some strategies and they don't work, go back to them and say, hey guys, you know, we haven't had success with this. And they are always so willing to come and help you again. I think what we're seeing is if you stop trying. So as soon as you accept that that's just the way they are, then that's where, you know, providers are falling over. So just be really mindful of that. And even if you can't do anything about it, just keep documenting that you're trying. The high prevalence, high impact. So just know exactly what they are. Make sure that they're on your risk register and know how they relate to that individual. So careful management, demonstrate the individual management of the resident. And I think the thing that we're seeing also is those, so if the malnutrition is related to diabetes, then just making sure that you're capturing the trail. So kind of follow the bouncing ball. The minimizing infection related risks there, I think that one's actually supposed to be over in my diagnosis related risk, because that was the example that we've seen now in 3 reports was there was a higher risk of infection due to refusal of personal care. When you're looking at those risks, like that, we all know that, you know, if they have a high FRAT, then they're a high falls risk, but actually really digging in and being specific to how that falls risk relates to that particular resident. So just saying that they are a high falls risk and we're engaging them in a strength and balance program or something might not actually get you through. And, you know, some residents are frequent fallers and do seem to, you know, just bounce back up and not actually injure themselves. So just being really mindful that you're not using broad-based generic strategies for everybody in relation to these risks. Deterioration and failure to identify it. We've seen a bit of an increase on failure to recognise cognitive decline. So doing the PASS or your mini mentals, if you're seeing that those scores are changing, then what are you actually doing about it? So it might be subtle changes that you're getting in clinical assessment, or if carers are reporting changes, what are you actually doing about it? So make sure you go back and you do the clinical assessment and you do identify if there has been a deterioration in their cognitive function. And then I just probably tools and resources. There are lots and lots of tools and resources out there, and these, I say, present a great opportunity for you and your service to, if it doesn't work, use it as an improvement. So the example I'll use is we recently at Innisfail, so we did a lot of behaviour support plans, and we really found the Dementia Australia care plan, some of the nurses really struggled with it. So, you know, we sat down as a team and we worked out exactly what each of those boxes meant and how we would answer it. And if there was duplication, then, you know, we changed it for that service. So if you have a group of clinicians, you know, registered nurses, get them in a room and get them critically thinking about the tools and resources that they're using, because if your nurses are not deeply engaged or they find the tools and resources, so those artifacts that you're using to capture this information, too difficult, then you're not going to get that to translate into care. So what we did at Innisfail is we still used a slightly modified version of the behaviour support plan. We still kept a behaviour register. So we still kept a summary on top of that. We kept it, we printed them out, so we didn't stay electronic. We decided that the staff needed to be able to access it easily. And so we kept it in a folder, and we still had the register on the front. So there was a quick reference to see, does this resident normally have this behaviour? And if they don't, then care staff knew it was a new behaviour, so they knew how to manage that. And if they did, they could quickly find how I should intervene and what interventions I should use. So I think just really try and make things as usable as possible. A disconnect between governance. So I think this is always ongoing, that so standards 8 and 2 are showing the highest rates of non-compliance, but 8 is normally linked to systems and processes or procedures in another standard, as you probably all are aware. So making sure that your governing body is engaged with clinicians, and again talking about those challenges. So if there's something not working and not seamless or streamlined, or you're finding it's a bit clunky, then talk about it and try and come up with a solution and use that as continuous improvement. I think another challenge around that we're all facing is obviously skilled and adequate workforce. So again, trying to spend as much time as you can. If you've got new graduates, or you've got if you've got nurses that are coming in on visas that haven't worked in the Australian system, then take some time to really introduce them to our standards and what our system looks like, and take the time to upskill them in the basics of aged care 101. And again, simply those tools and resources that you use. A couple of things that we saw that have triggered conversations in amongst our team were the concepts around informed consent. So I think good nurses always, the way I was trained was that we always asked, Mrs. Bloggs, are you right for me to do your dressing now? And she'd say yes or no. Hey, Joe, you ready to have a shower now? Yes or no? So that concept of informed consent is we've seen woven through the new strength and standards. So I think we'll just need to be really mindful that we're capturing that when, as we move into this new era, that we are capturing that informal informed consent. The example in one of the webinars, I think, was around medications, and it was around a psychotropic. So like I said, in the old days, we used to always say, so, hey, Joe, I've got your aspirin, or hey, Joe, I've got 2 Panadol and a XYZ here for you. So just making sure that that's, we're bringing that back into our practice. And, when we're giving, the example was when you're giving medications, every time you're giving medications, the resident knows the medication they're receiving, because that is consent. Trauma-informed care. So this was another theme. Obviously, we do a fair bit of work with some Aboriginal and Torres Strait Islander communities. So informed consent sparked a conversation for us. And, as nurse advisors, we've all done, had to go and do some professional development in that space. So I think we all do it to a certain extent, and I know for a very long time running aged care facilities, it's been very, but Australia Day is a good example. So talking to your Aboriginal and Torres Strait Islander residents and saying, look, it's Australia Day. What does that, if we do a celebration here, or if there is a celebration going on, or if you see the celebration on the TV, how does that make you feel? Is there anything that we need to be mindful of? Is there anything that we need to talk about? And and doing it or not doing it, how does the resident feel about that? So obviously this is a really deep area, and I don't think any of us will claim to be specialists in it, but probably asking the questions around, is there anything that you don't want to talk about? Is there anything that you would like me to get someone else that you could talk to about that, who is, far more knowledgeable than me and aware of maybe the travesties of the past, to support them will be important. There's some really good guidelines that are out, and I think if you, Lauren's going to be available for some contact, and she can certainly share what we have found and the conversation starters that we've had in our group. And communication, I think this almost happened when the single quality framework, so this current standards, when they came out, we almost moved towards individual communication agreements with residents, but I don't think we quite got there. But in the strengthened standards, we have seen those concepts kind of flagged again. So just be mindful that a resident might have next of kin, and they might have an EPOA, and they might have a friend or a family member, and the things that they want you to talk to each of those parties about are very different. So just because they're next of kin doesn't mean that they want the next of kin to know that they fell over, or they had an extra bowl of ice cream and we know that they're diabetic, or that, they, I don't know, all of those incidents. So just be mindful about what the resident and what their representatives are actually representing them for. So Lauren recently had, she said, so what do we need to do? What do we need to do to get ready? And she said, well, nothing yet, because the bill hasn't passed. But obviously that's a little bit different to what the Commission's saying. So I think build in some of those themes, really take the time to go through the latest evidence-based mapping material that came out, that really talked about, gave you the questions that they're going to ask you, it gave you the documents that they're going to ask you for, what they're going to ask staff, what they're going to ask management. That it's a, again, I'll get Lauren to share the link, but it's a nice little resource. It's a little confusing in the beginning because it's mapped to some concepts, but if you just kind of step back and don't try and align it to the actual standard or the outcome, just think about the concepts in the themes, then I think you'll be okay. And I guess that's something that we see, and any of you that have had a not met or a less than favourable visit, you will always see that if they find something in standard 3, then they can almost use that in, standard 1 to 7 and 8. So the new strengthened standards are trying to get away from that, and that's why I think they've created these 21 or 23 themes. I might just take a breath. Has anyone got any questions so far? Sorry, I should have probably asked you back at the compliance bit. No? And the 24/7 on call, I guess this is the other thing that we constantly see is really challenging providers. And, you know, as of March this year, we had to have that nurse on site, and there are some workforce strategies and workforce programs out there sponsored by the department that they can help you get some staff in. And you know, if you've got under those 30 residents, then you can get your exemption. But this effort to comply, just really document that well. If you are struggling, and if you do miss a shift, or you haven't, if you have some staff turnover, then just demonstrate your effort to comply. And that might be that you have a rolling recruitment strategy. It might be that you're engaged in workforce programs, but also demonstrate how you're managing the risk. So demonstrate what you've got as your backup plan. What are your on-call solutions? Do you have someone that is, you know, lives in the community that they can call? Have you spoken to the local ambulance, or if you're in a smaller place, a district hospital, and say, you know, these are the rules that we have to live and breathe by now in residential. We're struggling. This is, and have those open communications and document it so that the commission, when they come in, you can demonstrate your effort, and that will get you through. I am going to throw to Rachel to talk about technology, because she is our technology whiz. Where have you? Oh, there she is.
So as Sue mentioned previously, I guess the premise of CareLynx was initially using spreadsheets. However, you know, Sue found and Maureen found that when they left, often, you know, those sorts of things went by the wayside. And so introducing of technology, whether it be CareLynx or whether it be some kind of CIS system, so clinical information system, is really part of that technology roadmap. So I'm sure that everybody has seen the government's technology roadmap. It's been going for a number of years and continues, and there's actually a separate project now that's been spun off looking at you know, how are we going to standardise clinical information systems moving forward? And CareLynx is actually part of a focus group to look at that standardisation. So similarly to what we've seen with the medication management systems being standardised, you know, requiring My Health Record integration, similarly on the CIS side, you're going to see more and more of that. And we see, unfortunately, you know, a lot of the clients that we go into and assist as part of, you know, being not met, often they're utilising, you know, finance or rostering systems to try and do their clinical information system as well. And that's where often they are falling down. So they're not meeting the requirements, and it's 2-3 usually that it'll sit in. So think about your interoperability of how the systems that you're putting in place can work together. So if you're starting down your journey of starting to understand, you know, what sort of technology do we need, we often, you know, speak to groups and they just don't know what sort of questions to ask. So does, you know, your finance system have an API that could integrate with a clinical information system? Have you already integrated with a medication management system? What medication management system? Is that system getting used in your community? Is it readily available? So there's some of the sorts of things to ask, you know, when you're starting to go down the journey of looking at technology for your service. It is so important, and the focus around interoperability will just become more and more as we go down that technology and that digital roadmap. So any questions from a Sue perspective, you know, all of the amazing things. I have to say our team, we have, I think, close to about 30, you know, team members across allied health, nursing staff, finance, HR that work in our team, and they do an exceptional job. The results, I guess the impact that our team has helping individuals, older persons, service managers, staff, is the reason why I love being a part of CareLynx and everything that we do. So as part of this, we are offering the first sort of 5 people that email us at support@CareLynx to have a 1-hour free session to ask any questions. The team have lots of experience over decades. Sorry, Sue. You can't help, with age comes experience. So I think, we're here for you, and give us an email and Lauren will do a bit of a Q&A session for you and with you for 5 people. But maybe I'll hand back over to Sue so that she can, please ask any questions with regards to what we're seeing at the moment.
You're on mute, Sue.
Oh, I'm chatting away to myself. Okay, I'll give you one more helpful hint. If you have a visit and you get a report, just read really carefully what they're asking you, because when you get your report, it normally says you have 14 days to respond. Now, in the old days, we used to go back and say, no, you didn't see this and you didn't see that, and therefore I'm met in this area and da-da-da-da. I would encourage you all to read it, hop it on the chin and go, look, if there's even a germ of truth to it, just wait till you're 12 days in, then reply and say, thanks very much. We've received and reviewed your report and we accept your findings. This buys you another couple of weeks. So don't go back to them with all of the, we've done a continuous improvement plan. This is it. Here's the time frames, da-da-da-da. Just go back and say, we accept your findings. Thanks very much. We've added it into our plan for continuous improvement. And that then just gives you a little bit more time. They will come back to you and say, oh, okay, well, now send me your plan for continuous improvement. But the request is, on that, normally, unless you've got some serious risk, the request is that you have 14 days to respond. Not to, tell us. You just have to respond to their findings. So just be mindful. And then be really crafty about how you write your response. But if you're in that position at the moment, then take the hour with Lauren and she'll help you out.
Yeah. And I can say that's the last 4 clients that we've helped out. That has made such a difference. If we can get them before they've actually responded, it just gives us, almost 2 weeks to actually sort of come back and work with them to be able to put, the necessary things in place.
And just it takes the emotion out of it too, because, we all take it personally. So, yeah.
Any questions from anyone? I did want to just ask a question personally about your pathways. Are they similar in your pathways when you are referring to them as in like the InReach RAS pathways, or am I off track completely?
They're clinical pathways. So very simple pathways on how to manage, how to manage a wound, how to manage constipation, how to manage malnutrition, how to manage a fall. So it actually pushes so instead of the nurse or the staff member having to know the policy and the process, it's built in. So now if I've done my incident and they've had a fall, it says, have you completed the FRAT? Have you told the family? Did you do the environmental the risk assessment or the post-falls assessment or whatever that might be? Yeah.
Yep. So that they are sort of similar.
Yep. Yeah.
Yep. That's cool. That was for me. I don't have a clinical background, so there was a comment from, I think Emma had said there's also support, that because you were saying, this is a great support network, and it was great that you're saying that, because I've been saying this to my network. There's also the InReach team as well, which are here today as well, because they're a great support as well. So
and I just think share, you know, we're all in the industry together. So if you don't have something, you know, just ask, has anyone got a XYZ? Has anyone got a simplified behaviour support plan? You know, like just ask, because
that was lovely.
Otherwise you can waste hours.
So I appreciated that. Thank you. Those were my questions. Anyone else have any questions? Anoop, you usually have a nice question or two.
Yeah, I'm just wanting that in the risk thing. Is it possible to add? I think it will be beneficial for the end of life plan for the residents. That is one of the biggest concern that which we always raise when they visit and see. They want to see the end of life plan for the residents mostly done. So yeah, that is a bit difficult choice to have a chat with them, with the families and with them, and some of them they really are not at that stage yet. So just wait, and that really if something that which simplifies that concern is really helpful for others. If there is something that you can develop or something that which we can discuss each other, that which will be accepted by the commission, so that it all will help us, you know, to be in the same page, and will help us to rectify that concern of residents, those who are not having that end of life plan. Things may happen all of the sudden in aged care. For example, you know, residents just went for shower, came back, and you know, not responding, and they start, you know, don't know what to do, and there is no life plan is there. What to be done? Call ambulance, and a lot of dramas happens in between, and they find one is done by hospital.
That's right. So we encourage residential facilities to do it on admission. So when they're going through all of that documentation, it kind of takes the edge off it a little bit, because it's not as different. It's not a, you know, a targeted conversation. It's just part of all of this documentation that you need to do. And it's much easier, obviously, to have that conversation when you don't need the end of life plan. Because when you need the end of life plan, that's when it's a bit difficult. The other thing is, if you have a family that says to you, well, what does that mean? Then that end of life care, I think it's a care pathway too. I think it might be a Queensland Health one that says, well, what is comfort care? So if you actually just use that little, you know, assessment that, well, this is what we do, this is what comfort care is, and that's what end of life is, then that helps them understand, you know, that you're not actually choosing not to do anything. We're just choosing the way we're delivering the care at the end. It helps the clinician have the conversation as well.
Yes, definitely. And so what is the best way to tackle this experience survey? If residents experience survey.
Oh, yes. So there are some hints and tips around that. Make sure so you know that the commission is getting all that data in the back end, and we see that coming out. So make sure when you're doing that you're capturing anyone that has a lower rating, a lower satisfaction rating in the experience or quality of life, particularly quality of life. Am I as mobile as I want to be? Is my pain well managed? Am I happy? Because that's your depression scale. And there's another one towards the end which escapes me at the moment. Just be mindful that you do a clinical assessment around it. So if they say, I've got pain, and is it always well managed? And they say, well, no, not always. And look, my mum's 82 and she complains about her sore knees every day. But honestly, I can't do anything. I can't give her anything more. I can't rub anything out. Like, you know, we're topped out with managing these sore knees. Just make sure you've documented that, and there's nothing else you can do. Like, you know, and The mobility one.
Yeah.
Just, yeah. Indoors, outdoor access, mobility aids.
Yeah. So the next question is that, the restraints that we do for MSU residents, environmental restraints for those who are bedridden in MSU, and they're not coming out anyway for MSU. So we do the environmental restraint for when the door has been closed because they don't have access outside. So the residents, those who are outside also, if they don't have the code access, they can't remember, they don't know what to be done and sort of thing. So is that everyone is being applied for that? The whole team need to be there or just?
So sorry, I'm just going to rephrase your question. Are you asking that if your facility is locked down at any point, not just in the MSU, is it an environmental restraint? Is that the question?
We got a visiting hours that 8 to 5 is our visiting hours.
Yes.
And after that, we lock the main doors. And if a resident wants to go out after 5, so for example, after their dinner, they just want to go out and sit there and have that sort of feelings of atmosphere. And so they got their rooms, they can go outside. But if they come sit there, there's no office staff, only our RNs are there. Yeah. Which they are inside. Yeah.
So this was in our the last facility we were helping got this one. So we know that in residential, we've always had a lockup procedure. For as long as I can remember, we've had a lockup procedure. Yes, that resident needs to be able to leave, come and go as they please. If you use a doorbell to come back in after hours, as long as the resident is cognitively intact enough that they know how to press the doorbell, then you're fine. Again, add it to your residential agreement. So right up front, when you put in that information about your service, we have a lockup procedure. We lock our doors for the safety of our community at, I try and encourage you to leave it as long as you can. So if you can do like 6 till 6 or 8 till 8 or, something like that, try and have extended hours outside office hours, but we lock up. And so it's about lockup procedure. So when they sign their residential agreement, they know and they've acknowledged. I think it's going to depend on the auditor, because certainly the auditor that was at this last facility, hell or high water, she thought it was an environmental restrictive practice, environmental restraint. I would argue it, but if you can, there's the little tool that the Commission has put out. It's got the little house in it and it asks you some specific questions. There's a resource. Work through that, because it talks about, that's about environmental restraint. It's got the picture of the house on it. Work through that tool and think about how you're answering it. As long as the person has capacity, can come in and out, it doesn't matter if it's locked. Like if they have to ask someone to let me out and someone lets them out, have to ask someone to let them in, someone lets them in, then you're kind of okay because it's your security procedure. But I probably should preface that on saying, look, that could be unknown because it has come up just recently. And like I said, I would argue it, but again, there's sometimes no point in arguing. You just say, I accept your findings. And maybe if they sign, when they sign their residential agreement, they accept the terms and conditions that are in that agreement. So in that agreement, you've got, we have a security protocol. So in a way, they're accepting that the facility is locked up and that they're going to be, locked in or locked out.
So last question.
Sure.
So for the low floor beds.
So
low floor beds.
Low
beds. So what will happen is that we got a sit to stand tags are there hanging through the bed after the physio assessment for the residents. But some of the residents are very keen. We put the mattresses by the side or the floor mattress by the side to activate the alarm when they're getting out. But nighttime, they will try to put the beds down. But the sit to stand tag will be down when they are doing that. So is it a restraint or not?
It's a restraint. It's a restrictive practice. If you are restricting their free movement. So if that person can't get up from the floor on their own, you're restricting there. Yeah, it's a restrictive practice. And if you have a mattress, so a fallout mattress next to a bed, which if a resident stands on that mattress, it's going to compromise their mobility. Be really careful, because that's kind of a restrictive practice as well.
But they got the remote, which is handy for them, and the call bell if they want to get off the bed. No, okay.
Can't argue that one for you.
Just putting some options out. That's all I know. That
yeah,
much.
yeah. It's it's the same as the bed rail argument. The bed rail for mobility is still a bed rail. So if the person has the bed rail, the bed rail is a bed rail. Even if they're completely cognitively intact, they ask you to put it up. They want it there because it helps them roll over. It's still a restraint. Yeah.
I'm going to interject there. Did you have any other questions? Maybe Laura, you happy with the questions? Anyone else online? Zoe, if you wanted to type in any messages, or Peter? Sorry, we're running out of time. So I just thought maybe participants could take you up on that offer. I'm really sorry. This has been a great session. I do know that some people will go on to the next meeting. So I didn't want to cut this off because it was good.
Sorry.
No, not at all. This is why I let it go on, because this is what it's here for. I'm happy with our updates to if there's no questions, please keep writing in. If there are any further questions, either type them in the chat here, or we'll be passing on Sue and Rachel's details.